Welcome to the Anatomy of Inequity, a podcast that examines how systems, structures, and history shape health outcomes long before a patient enters the clinic. This podcast is designed for healthcare students and professionals who are willing to look beyond individual behavior and examine the conditions that produce unequal care, because outcomes aren't accidental and inequity has an anatomy.
All right, welcome to the Anatomy of Inequity. I have a very special guest on the show today, and I will pop her bio in the link so that you are able to review what's going on in her life. She is Miss Fabulous to me, so I'm not going to take a whole lot of time to introduce her because I want to spend most of our time talking to Dr. Don S. Brown. Welcome to the show.
Thank you so much, Rhonda. I'm so glad to be here and excited to share with your listeners and students.
Yes, absolutely. So let's get started. First question I ask everyone: what systems in your childhood most shaped what you believe was possible for you?
And that is a very good question. And it definitely caused me to think about just how I grew up. And I know we all have different lived experiences, different ways that we're socialized and grow up. And my systems are from an oppressive standpoint. I mean, given, how I grew up, low socioeconomic status, not having some of the things that my peers had, those systems of oppression, those systems of being marginalized really shaped my fortitude, shaped my resolve to persevere in spite of. And that's why I believe growing up, I strived to be the best student I could, getting all the great grades so I could come out of those systems and get into a college where I knew that once I graduated, I could make a positive impact on whatever profession I chose to go into, which of course happened to be physical therapy, and in society. And so being, resilient, as people say, persevering, I believe that those negative experiences, again, we're there for a reason. I'm a firm believer in things happen for a reason, a season, or a lifetime, and that helps shape what your present is going to be, what your future is going to be. And I take solace in those things happen to me for a reason. And I'm here to share and just help change the world.
Yes, and you are doing it. You are doing it. I appreciate that answer. Thank you so much. So now let's move into some of your body of work that you are currently engrossed in. You've presented the idea that belonging does not equal assimilation. For students in the clinic, how can they tell if they're being asked to just fit in versus being truly included? And how does this affect the care they give?
Yes, and I appreciate this question because that phrase fitting in is something that we need to get away from. And, I've done, like you said, my research. I published several edographics in the Journal of Physical Therapy Education that talks about belonging for learners or students and faculty. And when I say that belonging does not equal assimilation, I mean that students, learners have a right to feel like that they're connected, that they're valued in clinical environments, and that they should never be required to be something other than themselves, because belonging means that you show up in spaces as your true authentic self and not suppress parts of who you are. And students in the learning environment, whether it's clinical or classroom, can pretty quickly tell if they feel like or actually do belong. Because if students notice that they're changing the way they talk, that code switching that we talk about, then you probably don't belong. If they avoid talking about certain topics, let's say, your CI and other staff are talking about what they did over the weekend, what they ate, what music they listened to, and you feel like you can't talk about what you ate or what you did because it doesn't quite match what they did for fear of being ostracized, then you probably don't belong. If you think about you're having to adapt your personality because let's say you're pretty vocal and you feel like you can't do that in a clinical environment, then that's assimilation and you probably don't belong. And so when I did research with my colleagues, one of the things we published was an exploration of Doctor of Physical Therapy students' belongingness in clinical education, a validation study. That study also has our validated survey that students can take so that CIs and directors of clinical education can measure students' perceptions or sense of belonging. Some of those questions are as, if students feel like they don't feel competent because of the type of feedback that they receive, especially if they're getting more constructive or negative feedback. If they feel like they don't get support from the CI or that they can't ask for support from the CI, if they're not invited to social events outside of the clinical setting, do they belong? Or if there's not even something as simple as acknowledgement of milestones. It's your birthday and they don't even acknowledge it, or you passed the board exam, you took it early and you're still on clinical rotation and they don't acknowledge that, then that makes you start to question your belonging. And so we know that true belonging occurs when your perspectives, your lived experiences are invited, and that CIs model curiosity, and that they're not being defensive when you bring up something that doesn't quite match their perspective, but they become defensive. That's not belonging. And so when students feel like they have to fit in, they're more likely to mimic what they see. When it comes to patient care, you have a CI that's managing a patient per the patient client management model a certain way, but you know as a student, it's not grounded in evidence-based practice. You're not going to say anything. You're just going to do it because the CI is doing it. You don't want to be an outcast. Or, if you have a CI who speaks to certain patients a certain way and doesn't acknowledge their cultural identities, then you're more than likely not to do that as well because you don't want to be seen as that outlier. So when students feel like they belong, then they can bring their full critical thinking, they can bring their creativity, and they can bring cultural awareness to the patient encounter. So the bottom line is that when students not only feel like they belong, but they actually belong, then they learn. That professional identity formation that we talk about in education, that's being enhanced. And then ultimately they can provide more authentic patient-centered care because the student is being true to themselves.
I had to turn my audio off because I'm just sitting here shaking and rocking as you're talking. That was so powerful. Thank you so much. I'm going to leave it right there because I got 20,000 comments, but I want them to hear you and not me. All right, so let's move on. Based on your research then, regarding belongingness in clinical education, what environmental factors in the clinic make health disparities worse for a student or a patient?
Yes, and I'll speak from both of those angles. So for a student in a clinical environment, those disparities are amplified when a student shows up to the clinic and now they're thinking about who's getting mentorship. So let's say there's more than one student in that clinic and certain students are getting mentored a certain way, but that student is not. Then is that a disparity? Are students allowed to make mistakes? And if they do make mistakes, then how are those mistakes brought out as far as the CI correcting them or helping them learn from those mistakes? So that can lead to disparities. When it comes to students' input, which students' input is validated? Which students' input when it comes to patient management and patient care is not validated? That can also lead up to disparities. So when students feel like they're marginalized or students feel like they're not seen, then it's going to affect their confidence. It's going to impact their opportunities for deeper learning so that they can show what they're capable and able to do as it comes to eradicating some of the health disparities that their patients will encounter. And then when we talk about patients and we talk about how disparities show up in the clinic, clinicians and even students, because students tend to emulate what their CIs do, but clinicians, when they don't acknowledge social and structural determinants of health, and they rely upon this one-size-fits-all model to care for patients, then that's going to create gaps and that's going to perpetuate health disparities, especially for historically marginalized populations. So as an example, something that really frustrates me in clinical care, because I still practice, is when clinics do not get certified interpreters for patients who have limited English proficiency. It doesn't take a lot to hire a service for people that are certified to allow that patient to engage in the care. And I always say, what if the shoes were flipped? What if you had limited Spanish proficiency? What if you had limited Polish proficiency? How would you feel if a clinician is constantly pointing to equipment and not able to talk to you? How would you feel if they're using broken Spanish or broken Polish to try to communicate with you? When you don't do something as simple as get certified interpreters or have one of your clinicians or techs become certified, then you're perpetuating health disparities. And even thinking about transportation, some of the patients, depending on where they're located, may have barriers to transportation. How are you being attentive to that? Again, social and structural determinants of health to ensure that the patient can get to the clinic. How are you adjusting schedules? How are you adjusting things so you can meet the patient's needs? So if we don't address these disparities, and we have students that are watching what we do as clinicians and CI, they'll start internalizing those inequitable practices, and they're going to start doing the same thing. So the system keeps going on and on and on.
All right, let's move on. Wow. You are currently exploring intersectionality in the future of PT practice. How does ignoring a patient's various identities, so we're talking about race and gender, for example, lead to gaps when we see in orthopedic, let me say that again, lead to the gaps we see in orthopedic or acute care outcomes?
Mm-hmm. And intersectionality, yes, that's the work I'm currently doing with a group of my colleagues. And when we think about intersectionality, we have to go back and give credit where credit's due. So Kimberly Crenshaw back in the late 80s, early 90s reminds us that people don't move through the world with just one identity, that we are the culmination of multiple identities. Even though when you walk into a certain space, people might immediately recognize one of your identities. So for example, when I walk into a certain space, they automatically see me as Black. And then they might say, okay, now you're a woman, and yes, you're tall, and yes, you speak English, and as I talk further, or yes, you must be educated, etc. But we have to recognize that we don't move through the world with just one identity, that we have multiple identities that make overlapping identities that make us who we are, whether it's our race, ethnicity, gender, our sex, our socioeconomic status, our language, etc. And when we ignore the intersectionality of those identities, especially as we're talking about healthcare, then we start making clinical decisions that are based upon partial information, and that's a problem. So for example, you brought up orthopedics and acute care. So let's just look at it from an orthopedics lens. We see disparities in pain management for women, especially as compared to men. And we also see disparities in pain management when it comes to people of color versus white people. And then if you add those two together as an intersectionality of identities, what happens to those experiences of pain management when you are a woman and you are a person of color? We can't ignore how that might accentuate disparities in pain management overall. You asked about acute care. Let's say, for instance, just as an example, you are looking at mobility recommendations in an acute care setting for a patient that has a disability. And we know that those recommendations may vary. And you're looking at recommendations for mobility for a patient who might have a certain socioeconomic status. Let's say it's a lower socioeconomic status. Then you bring those two together. You have a certain disability and you have a certain socioeconomic status. Let's say it's lower. That will have an impact on what type of mobility device you will be afforded to have based upon those two sections of your identity. And so we recognize that gaps in healthcare, and including physical therapy, happen when it comes to intersectionality of identities, because our healthcare system, and even to this day, is still built around norms that privilege certain identities over others, that privilege historically dominant identities over others, and these health disparities and these gaps still persist. And it's our job to try to eradicate them. No matter how slow the process might seem, we still have to take strides toward doing that. And so when we apply this intersectionality lens, then we as physical therapists and physical therapist assistants and students can better recognize and appreciate how these identities shape a patient's access to healthcare, how it shapes their risk for certain diseases, how it shapes their trust in the system, and even their overall goals. And so when we put on this intersectionality lens in whatever setting that we have, then it allows us to have more accurate diagnosis, if you will, from a physical therapy perspective, to be more responsive with our interventions and tailor them toward the patient and their identities, their lived experiences, their perspectives, and ultimately provide better patient outcomes.
I'm going to school over here. I appreciate this. Okay, so now let's shift into talking about moral courage.
Yes.
You've been vocal about leading in the face of the anti-DEI laws, and will soon be honored for your work at CSM. Yay, 2026.
Thank you.
What does moral courage look like for a new grad who sees systematic unfairness but is just starting their first job?
Yes, and I know that can, and thank you for the congratulations. I am so humbled and honored to receive that recognition with my co-author, because, as a side, when I was at one of my previous institutions, A person who was like a mentor to me said, turn your pain into a publication. And especially in today's socio-political climate, when all these challenges to diversity, equity, and inclusion came to pass, it frustrated me to no end. And I was like, I started writing things down about what our associate is and is not doing about this, and invited a colleague to join in on the project and said, we need to publish this because we need to stand up for this. And so that's where the moral courage comes in. And so I know that a student coming out on their first job might feel that they can't be courageous to stand up because they want that job, first of all, they want that income, and they want to be able to move on with their professional career. But we have to recognize, whether you're a student or a clinician, that standing up for what is right, even when it feels challenging and even when you might face some risk, is the right thing to do, because it has future implications. And so when we think about moral courage, whether you're a student or a clinician, it doesn't mean that you have to be the loudest voice in the room. It doesn't mean that you have to be confrontational. That's not what it's about. It means that you have to, especially as a new grad going for your first job, that you have to be consistent and do consistently small acts that align with your values. Because the moment that you depart from the values that you have, then you're part of the problem. And so it could be, as a new grad, as something as, again, I say simple in air quotes, as saying, well, I'm not sure that this plan that we've devised or that you've devised for this patient is the most equitable. Can we talk about this? That's standing up. That's exhibiting moral courage to have that discussion. Or advocating for a patient that you might see in a clinical setting as a new grad who's constantly being dismissed, that you see that they're not treating equitably as compared to a similar patient with a similar diagnosis, standing up for that patient. So it's about, as a new grad, being willing to learn what the right thing to do is. It's being willing to unlearn what the wrong things to do are as it relates to even our professional core values and code of ethics, and relearn what you need to do to stand up and exhibit that moral courage in spite of the challenges and the risk, because this will have a positive impact on not only yourself, but on the patients, on the community you serve, and on society. And so, and as for new grads, sometimes they feel, well, I'm a new grad, I got this new job and I don't want to jeopardize it. And how do I even exhibit moral courage when I'm just a staff member? I don't have a leadership role. You don't have to, because moral courage is about integrity. And new grads should remember, just as us seasoned clinicians, that's one of our core values. So you are charged, once you enter the profession, with modeling integrity. And so it's asking those challenging and hard questions. It's speaking up when something doesn't quite feel right. And it's holding space for patients, for colleagues, for anyone whose voices are often overlooked. And so new grads have to recognize you don't have to fix the entire system all at once. Make an influence right now, right here, to affect some kind of change. Small steps add up to larger steps in the long run.
Amen. The way you eat an elephant is one bite at a time.
That's it. I agree with you.
All right. Last couple of questions. Your upcoming work moves beyond cultural competence towards health equity and humility. How does shifting to a humility mindset change how a PT treats a complex patient?
Yes, and I with the words cultural competence and cultural humility, I know that oftentimes they're interchangeable. And one of my research partners and I had an edugographic, and we presented at one of the combined sections meeting about how language matters and evolves over time. And this is an example of that, where back in the day, we talked about cultural competence. And fast forward, we're more talking about cultural humility, because when you think about those two terms, they are different. And I explain this, I do with two of my colleagues, the mandatory cultural humility module for Illinois for licensure. And when you think about the shift from cultural competence to cultural humility, you have to recognize that it moves us away from the idea that we can master someone else's identity, their experiences, their perspective, that we can learn about it and then take a test and check. We know all there is to know about you. No, because humility now positions us as clinicians, and even the students, as a partner in wanting to continuously learn about someone's culture and not being the expert of their culture, even if we share the same culture. I can't speak for all Black people. I can't speak for all women. Just because we share a certain identity doesn't mean that I'm the master of that culture. I am constantly willing to exhibit cultural humility and learn and recognize when I don't know something and go find something out by asking asking instead of assuming and leaning into stereotypes. And so when we think about clinical practice, this means approaching every patient encounter with curiosity instead of assumptions, instead of these stereotypes. It means asking patients, and I'm a big fan of when I teach the Kleinman's 8 model of questioning for patients. Tell me about how you feel about this disease or diagnosis. Tell me about what have you done about it? What would you like me to do about it? How has this shaped you? What matters most to you about how we together can help you achieve your highest level of function? We want to make sure that patients are a partner in their own healthcare. We want to make sure that we support health equity and recognize our own blind spots when it comes to the culture of the patients that we encounter. And so part of it, you ask about complex patients, and it's the same thing. Our whole thing with any patient, whether they're simple or complex or a combination of the things, is looking at them from a holistic lens. What makes this patient complex? What makes this patient who they are? And then adapting our treatment plan accordingly. And again, not making those assumptions that, oh, I'm culturally competent. No, if we exhibit cultural humility, we're always open to learn from the patients so that we and the patients together can try to move toward creating equitable, sustainable, and meaningful outcomes.
Wow, 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 wow. This has been a wonderful class. I hope that the students that will engage in this conversation really get where you're coming from. I really appreciate that you've been able to share some time with us. So we're going to end this segment. I don't want to, but we're going to end this segment with the last question that I like to ask everyone. How, and I know the answer, you really almost already said this, but formally, how are you intentionally building a legacy that actively dismantles health inequities?
Yes, and I appreciate that question, and that's actually a question I pose to students that I teach. For me, it is, building that legacy, as you say, is, being that person, being that leader that I would want to follow, being that person that I can help cultivate others, to help empower others, to help inspire others to do the right thing, to exhibit that moral courage in the face of adversity, to be able to inspire and empower and help people exhibit that cultural humility, because that is what we need more of, especially in today's socio-political climate. That's what we need more of. And so the legacy is not about me. It's always been about, regardless of whatever position I've been in, whether it's a leadership position, whether it's, where I teach, what committees I'm on. It's not about, or even the awards that I receive. It's not about that. It's about using the spaces that I have been blessed to be in, the people I've been blessed to come in contact with, such as yourself. How can I use that to help others to be able to move along and be able to make that same positive impact that we all collectively can use to make the positive change that we need in this society?
Well, you have rocked this podcast out, and I just want to thank you because you so much have been an influence in my life and in my ability to thrive in this crazy climate. So I appreciate you so very much. Thank you so much for being here and being in this space and for sharing your knowledge with us. Thank you.
Thank you so much for having me. This has been a blessing. And like I said, anytime I have an opportunity just to share and interact with students, with people such as yourself, I'm all in, because together, collectively, we're better. So that's what we always have to keep in mind.
All right. And that's our next episode. Thank
Thank
you.
you so much.
As you move forward in this course, remember this: health disparities are not simply about patients, they're about systems. And as future clinicians, you don't just treat bodies, you practice within structures that either reinforce inequity or interrupt it. Reflect on how this episode connects to student learning outcomes and how that understanding may influence your clinical perspective. This is the Anatomy of Inequity,